Welcome to this IC on Target Emmetropia, refractive cataract surgery. And as all of you all know, today cataract surgery has become a refractive surgery, and most patients expect glass-free vision after cataract surgery. So there are various aspects that have to be considered when you're able to give a patient emmetropia, whether you're using a monofocal or a premium lens. For premium lenses, it becomes more critical because if you're off on your target emmetropia, then it can give rise to a lot of problems and patient dissatisfaction. So today we will look at the various aspects that contribute to how you can get emmetropia and a happy patient. Before we start the IC, it is my pleasure to introduce the keynote speaker. We have Professor Mario Jose Tassion from Belgium, and she is a past chief and chair of the Department of Ophthalmology from the Antwerp University Hospital and University of Antwerp, emeritus member of the Belgium Royal Academy of Medicine. She's also a member of the International Academy of Ophthalmology and member of the European Academy of Ophthalmology. And she's going to talk on her long-term experience of bag in the lens in pediatric cataracts. And I welcome Professor Maria Tassion to give her talk.
I hope that you, yes, this one is working, this one is not working. Well, thank you very much for this kind invitation, and I'm really honored and very, very pleased to be in Delhi. This is the first time that I'm in Delhi, and although I came already many times in India, but India is of course a very big country. These are my disclosures, and I will indeed speak about pediatric cataract and what I discovered or what I found out by operating quite a lot of children with the back in the lens technique. And indeed, the back in the lens technique was in fact developed to eradicate posterior capsular opacification after implantation, first in adults, but then of course also in pediatrics. And we start from 2 months old, we start operating the children and implanting that lens, because that lens is completely independent from the capsule bag and thus not can be implanted in very small eyes as well. Now, I don't know how many people do know about the burger space and know where the burger space is located and what is behind the lens, because of course the burger space is indeed a space that is just behind the posterior capsule of our natural crystalline lens. And although this space has been described already in 1884, it is not really very well known. But I want to make a change on that, and what we discovered is an amazing area that is most probably one of the areas that is also involved in our accommodation. And when we lose our accommodation is because that space starts to become loose and that we have that ligament of Wieger that comes loose. Now we have to, of course, to perform a back in the lens, we need to perform a primary posterior capsulorhexis. To do that, you have first to fill the anterior chamber very thoroughly, to be sure that the capsular bag is in a horizontal position, puncturing the capsule bag that as you have seen, and then you are absolutely sure that your anterior hyaloid is far away from the posterior capsule and you cannot harm it, not at all. So I think that these are ones that you know about the anatomy, then you know you are not so much afraid to do that act of posterior capsulorhexis. Now, babies, they have a smaller burger space. In fact, the burger space will also grow depending on the growth of the eye. And here what you have to remind is that we have the anterior capsule is in red colored, the posterior capsule is in blue colored, and the anterior hyaloid is in green. And you have the circle there, that is the ligament of Uyghur. Ligament of Uyghur is the area where the posterior capsule meets the anterior hyaloid, and it is a very large space in children. Now, indeed, in children, the space is not so large, and the risk if you implant an adult back in the lens is that the posterior capsule will be pushed out by the haptic, and then you can have escape of cells. So what we do then is to do a stretching maneuver. Stretching maneuver of both capsules. We pull on both capsules so that we detach a little bit. What a natural detachment would do, now we do it mechanically by a manual maneuver, so that we are sure that we have a space that is big enough. Now, I would like to there are so many variations in the anterior segment of the eye than there are pediatric cases. So it is a very, very, very difficult thing to explain thoroughly. But here, for example, as soon as you see that you have here the processes ciliari that are stretched and dragged to the center, that means that there is no normal vitreous relationship between the capsule and between the anterior, between the capsule and between the vitreous. So in those cases, most often there is even no Berger space present. And here you see the dragged ciliary processes that are attached to that plug here just in the middle, and those ciliary processes, and you see it here on OCT as well, they provide blood to that remnant of what was in fact the PF, which is in fact a PFV, a primary fetal vasculature. So you see here, for example, that if you look it very well enlarged, you see even the red cells passing in the vessels. So very beautiful, amazing. Now, of course, the idea was, or the tricky thing is, do we find, I know I cannot do it. No, it doesn't work. So the idea was, can we separate without harming and without inducing hemorrhages, because we know that that is vascularized, can we separate that structure, that vascular structure, from the posterior capsule? So here again, a little puncture. This is a 41 gauge needle that I used and I borrowed from the vitreoretinal surgeons. They are used to use smaller instruments. And you see even that remnant of the cloquet canal that is there at the back here. Here. This is the remnant. You see it moving, and that is the remnant of the cloquet canal. And so you see now that by performing the posterior capsulorhexis, I can pass by the processes ciliari that are dragged, and no bleeding at all. Nothing happens, so that is fine. And then you can implant the back in the lens just like if it was a normal place. If I could go, maybe that now I can do it, because then no, I cannot drag it. I just wanted to show you, once that it is freed, how beautiful it is separated from the remaining of the vitreous, and you even do not need to do a vitrectomy, because there is almost no vitreous present in those abnormal things. What is of course absolutely necessary to do is to coagulate those vessels, so that you are sure that when you are cutting it out, that you have, you see, I can go with a blunt instrument, I can go behind the posterior capsule, and I have no obstacles. So that means there is no ligament of Uyghur present there. So there are quite a lot of variations in the ligament of Uyghur. Sometimes it is lost from, or not present, even not developed. Here you see that's the ergolet space with the anterior part of the cloquet canal that I'm taking out, and then back in the lens can be implanted. So in children, you sometimes have even no Uyghur ligament that has been performed, or no Berger space at all. In adults, with time, and for those who are older than 65, the anterior hyaloid will detach spontaneously due to aging from the posterior capsule, so that there is no support anymore by the lens, and that is one of the reasons why we also have less accommodative power, because the lateral power of the water over ciliary body cannot have any effect. Now, another thing that I wanted to address is performing a sized and centered anterior capsulorhexis by using flax in very difficult cases. Is it possible? Yes, it is possible. And here you have different cases that we have done. Here it is a child that we will see later on okay. Here, this is a child. This is an opacification, calcification. So doing it, the anterior capsulorhexis is relatively difficult because it's anteriorly located in this child. But in the other cases, it's more posterior cataract, then the anterior capsulorhexis can be performed quite easily. Now, in this case, you think, are you already 100% sure that you have performed a full anterior capsulorhexis? Well, no. If I can forward here, I can show it. No, it is not progressing. Now I cannot grasp and show. But here there was a little, because for the sake of time, I think that I have to close. And so I just want to say, even in children, but anterior capsulorhexis is not that easy, because the anterior capsule is extremely elastic. So that means that you really need to have a straight plane, otherwise you have a little bit retardation in the effect of the femtosecond laser on one side. You even can do an anterior capsulorhexis in a dislocated lens, that's also possible. And then the question came, can we do eventually a posterior PCCC with flax? That would also, of course, be very, very useful. But I would propose to do that in cases where anyway the anterior interface is not very well defined. Now, we have already 55 papers on that topic of the back in the lens. These are the most important ones. And I thank you very much related to this paper. And I thank you very much for your attention.
Thank you so much, Professor, for that insightful session. We're very lucky to have you, a pioneer of this technique, here with us today. And thank you so much for your insights.
I'm very happy to be here. Thank you for the invitation.
So moving on with our instruction course of Target Emmetropia, our first speaker, I would like to introduce to you Dr. Shreyas Ramamurthy. He is a cornea cataract and refractive specialist, and he runs the Eye Foundation group of hospitals. Today, Dr. Shreyas will be giving you an overview of biometry devices, and we know that biometry and an accurate biometry is the first and most important step in achieving emmetropia, especially while using premium IOLs for spectacle independence. So we'll be looking at biometry from Dr. Shreyas.
Thank you. Thank you so much, Supriya, and thank Sri Ganesh sir also for his kind invitation to this course every year, and really look forward to always the discussions and the topics that happen every time. So today my duty is really to run through some of the overview of the biometry devices that we have available today. And whenever I deliver this talk, I am very fond of starting with ultrasound biometry. While it is probably, you hear it in many places, that optical combined with tomographers, combined with swept source OCT is the only way to go. I still believe ultrasound biometry has a role in our country, where economic factors are a problem. And when you're using ultrasound biometry, probably what we should completely discard is doing a contact biometry, and at least switch over to a immersion biometry. I will go through some of the aspects of where it actually differs, but with axial length being one of the most key variables, a difference between a well done immersion biometry and optical biometer in most eyes is below 0.1 millimeter of agreeability, where the IOL power really doesn't change much. What we really need to look into is the high quality A scan, ensure your spikes are in place. If the spikes are not prominent, then probably you're likely to have a greater probability of having an error, and ensuring you adjust the gain according to whether this is a denser cataract or whether there's silicone oil inside the eye. Increasing or lowering the gain accordingly is also important ways of ensuring that even in a difficult situation you get a very good axial length measurement. Probably the only area where we would not get a good repeatable measurement with ultrasound is in our eye with a posterior cephaloma or highly myopic eyes, where essentially we would be measuring the anatomical axis and not really the optical axis or the visual axis. And that is where the optical biometers would stand over an ultrasound biometry when it comes to an axial length measurement. Now moving on to keratometry itself, the manual autorefractometers, manual as well as the autorefractometers give you a good keratometry measurement, and you could use it in combination with an ultrasound biometry as well. With all the online calculators available today, even with that you can give excellent results in most of your premium IOLs. With the optical biometers, there's little to choose from. All of them have excellent agreement. Tomography measurements, especially in post-LASIK eyes, definitely has a role to play. The number of points measured seems to have less importance than the fact as to where they are measured. So because most of the regression formulae are based around the 3 millimeter zone of the cornea, as long as you get repeatable measurements on that central 3 millimeters, the device itself would matter less. One advantage with the telecentric keratometry is, while even if the patient is not so cooperative or the biometrist who's doing it is not focusing it perfectly, the distance between the spot remains the same. So therefore, even if the spot is blurred, you're measuring over the central same 3 millimeter zone of the cornea, and your repeatability in the measurements is much higher because of this particular aspect. What's really made a true change in the way we view biometry is our understanding of the posterior cornea and the posterior corneal astigmatism and the posterior corneal power itself. While regression formulae were useful and assumed a fixed ratio between the anterior and posterior cornea, we know that need not be the case, and especially in post-LASIK eyes where the ratio has completely been shifted, the total keratometry, which projects over the posterior torus points from the same anterior points, the 3 millimeter zone which you're measuring, the same points are projected onto the posterior cornea, and you get the posterior torus fit, which really gives you a very accurate measurement of the posterior cornea. Now we already had posterior corneal measurements from Scheimpflug devices, but the problem with it is that the way the Scheimpflug device derives the posterior corneal measurements were not applicable to the formulae, the biometric formulae that we use. It was not that the measurement itself was wrong, but it was not applicable to the formula. So that is where the total keratometry, having its own measurement formulae, has become more useful. And while we know that when we put in the measured values in the online calculators like the Barrett or the Baylor nomograms, we find that the mathematical measurements are better than the one derived from the Scheimpflug devices. But not as much with the case of the TK formulae, which are regression formulae calculated essentially for the total keratometry from the IOL Master 700, where you have the Barrett TK Universal 2 and the Barrett TK Toric from this biometry device, and this formulae seems to give better results both in virgin eyes as well as make a truly better difference in post-refractive surgery eyes, wherein the Barrett TrueK TK gives you a better performance. And to corroborate this further, it was not just with the Barrett TrueK TK, even with the Haigis formula, when you use the Haigis TK, it gave better results than the Haigis L or the ASCRS average and the Shamas. So therefore, going for a measurement of the posterior cornea seems to be the way to go. Along with that, it gives you an angle alpha and angle kappa measurements as well, which is quite useful. The ACD measurements, which really are important for the ELP calculations, which are an integral part of most IOL formulae nowadays, are definitely better with the newer biometric devices. While the older ones were measuring from the epithelium and tended to overestimate a little bit more, was not very suitable in pseudophakic eyes. In pseudophakic ACD, there was a greater range of error. But with the IOLMaster 700, you are getting a B-scan biometry, which gives you a greater measurement of the anterior chamber depth, the lens thickness, and thereby ELP calculations become very good. Apart from that, having a good image of the foveal fixation also ensures that your repeatability of measurements can be ensured when you are able to image the foveal pit. When you don't image the foveal pit, you see that the variability of the measurements tends to be wider, and the IOL power selection itself can become quite significantly different. So this is one way of cross-checking whether it was your difference or the error in your biometry versus an error in the IOL power formulae. And like already mentioned, both pre and post-operatively, this B-scan biometry or the swept source OCTs gives you a better prediction of ELP and ACD measurements. You can also look at the macula. And of course, most of the devices today are able to penetrate a little better, whether you're talking about the Argos or the various other devices which are now available, which combine biometry and topography. Now, this is the next step where the same device is now measuring your topography as well. However, the range of topography is quite variable, where some of them just give you an idea, a simple picture, whereas the more advanced ones like the Anterion give you a kind of a Scheimpflug device, an OCT based topographic image, which is almost comparable to that of what we get in our Pentacam or Galilee. Reverse of that, you also have primarily tomographers which have axial length measurements like the Pentacam AXL or the Galilee G6, which are essentially Scheimpflug devices but giving you a good axial length measurement as well. So with all this, how do we choose from? The good news is that the results are very, very comparable, whether you're using a tomographer which is giving you axial length or versus a biometer which is giving you a very superficial, very simple anterior Pseudo based topography. Anterion seems to have a combination of both, along with the MS39, seems to be one of the best devices for measuring various components of the eye. For paucity of time, I will not go into the details, but when you are looking at biometry today, we are looking at a whole lot more than just a keratometry and axial length. We are looking at white to white, we are looking at the lens vaults, especially with regard to phakic IOLs, the vault of the natural crystalline lens and the vault of the phakic IOL. All these measurements can be put in place. However, certain other devices, this is from the Aladdin, where you have a little more basic, simpler topography, but more than enough for your regular cataract patients to decide whether it's orthogonal astigmatism or not. This is from the IOLMaster 700, where you have this. You also get it from the Lenstar 900. Hagstraight has a reasonable, now the newer version has a nice topographer built in. So really, with the advanced imaging systems and the combination with IOL power formulae, which will be dealt with in the upcoming talks, Emmetropia for all types of patients is a real possibility. Thank you so much.
Thank you so much, Dr. Shreyas. I think it's always for people who are starting their practice a point of confusion which biometer to actually invest in and go for. So I think that gives us a lot of insights. Thank you so much. We'll reserve questions.
I think I didn't go into the commercials, but that will be a separate topic later.
We'll keep questions towards the end of the IC. So we'll move on to the next talk. I would like to invite Dr. Gaurav Luthra, sir. Dr. Gaurav Luthra sir is the director of Drishti Eye Institute from Dehradun, and he's a prolific cataract and refractive surgeon. We are lucky to have you with us here today, sir. Dr. Gaurav will be discussing the IOL formulae and their details, which formulae to use and when to use them. I'd also like to mention that I'm required to say any commercial names of medical devices, software or equipment may appear in this content because they're linked to specific medical procedures which are the focus of this training material. Other products on the market can be used to perform the aforementioned medical procedures. The educational provider does not endorse any particular product. Thank you.
Thanks, Supriya, and a very good afternoon to everyone. And I'm lucky to be in Sri Ganesh's course for the last couple of years. And excellent talk by Shreyas on various new devices, and they keep getting better every year. And so do our formulas for IOL power calculation. We keep learning new things each passing year. So it's really evolved. We've seen this evolve. I started doing cataract surgery somewhere in 1992, and then we've seen how this has evolved. The first generation formulas. I remember, memorizing one of the formulas, which was the SRK formula, and then that's when I came in. And after that, we've actually grown the third generation formulas, the Hoffer Q, the SRKT, which again still remains very relevant. Then the fourth generation formulas like the Olsen and the Haggis and the Holiday 2, and then of course these newer formulas, and then yet still we have more things coming up like the ray tracing and others. So this is how it stacks up, and this chart keeps getting bigger and bigger with every passing year. As you can see, the shorter eyes, the normal eyes, and the longer eyes, and on the right you'll see that these formulas from here till here are those which are for the normal anterior segment anatomy, and the lower ones are going to be able to cope with all the other types of anterior segment types, which means shallow ACs and deep chambers and long eyes and short eyes. Similarly, on the left you'll see that these are the Virgin's formulas right up till Holiday 2. Olsen C is a ray tracing formula, and then the Barrett's and the Hill RBF, which have become really our mainstay, and we hardly ever go to the other formulas now in our practice. We stick to the Barrett's, which works from the shortest to the longest eyes, and the Hill RBF, which seems to have even a bigger, the Hill RBF 3 has gone, for these unusual eyes, it has gone beyond even the Barrett's maybe. So if we look back at SRKT, which as I said still remains relevant sometimes when you're doing ultrasonic biometry, when optical biometry is not possible, it tends to still give us a great result, and it predicts the ELP using the axial length and the corneal power. And this can be used, should be used for eyes which are longer than 26 mm even today, and whereas for the regular eyes between 22 and 24 millimeters, you can use the Hoffer Q, the Holiday 1 and SRKT as well. So the SRK 1 and 2 are now obsolete and should no longer be used. The Hoffer Q is basically, we've all used it for shorter eyes, and it basically gives you a personalized ACDs developed from any given series of particular IOL styles, and then this is used, the axial length and the corneal power is used to predict. Now this is it still stands the test of time for eyes which are shorter than 22 millimeters, although now Barrett's and the Hill RBF have become really good with the shorter eyes as well. The Holiday 2 again takes into account several parameters. So it's 7 parameters are used for predicting the surgeon factor, and these are all the factors which can be used. And it is again recommended from the short to the long eyes, and using the Wong-Kok adjustment, it has been shown that it can be used even from the short to the longest eyes with the meniscal IOL designs. So that WK adjustment really helps increase the range of these formulas. The Olsen C came out many years back, and this was came out with a lot of promise with the ray tracing constant or C constant, which it was using to predict the ELP, and this was popular in the beginning. I don't use it anymore, and it is still used by a lot of surgeons. I in fact had the opportunity to work with Hill RBF formula with Warren Hill, and we were providing him data of the Indian database with the artificial intelligence. So basically the Hill RBF started off as the first formula which was using artificial intelligence. The Hill RBF 2 came up in 2018 with a bigger database, and essentially it was trying to tell you about the eyes which are falling into the normal group. So it dramatically increase the range from the short and the long eyes up to 40 diopters and up till -5 diopters. And they increased the number of eyes database which was used for creating these deep learning models to just about 12,419. So this included a lot of short axial length and long axial length eyes. So essentially this formula it's not a formula, it's basically a deep learning algorithm, and it tells you whether what kind of IOL power it is predicting based on the database, and then it'll also tell you whether the prediction which it is giving is within bounds or out of bounds. So those eyes which are within bounds are essentially those where it tells that the accuracy is great, and where it says that it's out of bounds, it will still give you a power, but it may not be as predictable as it is with the eyes which are within bounds. So you can also aim for residual errors. So if you want to aim for a myopia of say -1 or -2 or a +1, you can feed that into it, and it will still give you a very good power calculation. And it comes integrated with the Abulafia Cock toric calculator, just like the Barrett's toric. They are about the same, so there's no big difference on the toric calculation between the two. So the Hill RBF is actually built into the Lenstar. It's a Harkstrite proprietary thing which has a kind of a monopoly, but then the Hill RBF is also available as a free calculator online, and anybody can use it with optical biometry. So it comes by rbfcalculator.com. I think that's the site which is used. So this actually Hill RBF evolved to the version 3 sometime back, and there again the range was further increased, and it was also taking into account the meniscus designs till the -5. And now it also took into account 8 variables. When it started off, it was taking into account only 3 or 4 variables, but now to have more out of bound cases fall into bounds, they actually have included more variables. So you can use lens thickness, the white to white, and the central corneal thickness, and even the gender, for giving even better deep learning artificial intelligence based calculations, and this has really made this formula even better. However, if you don't have those all variables available, you can still get along by having the 4 basic variables, which will still give you a calculation, but it won't be as effective. So now coming to the Barrett suite, which has become, I think, the go-to formula for most of us who are using optical biometry really. And the Barrett suite, which also has 3 formulas. For the Barrett's Universal 2 for all the non-toric IOLs, the Barrett's toric formulas, which is basically the Barrett's Universal with the toric calculator, and then the Barrett's 2K. These are the most important basic formulas from the Barrett suite that we use. The Barrett's 2K is basically for all the non-torics after post-laser vision correction, and this again is very, very useful and one of our go-to formulas for post-refractive surgeries eyes. Again, the Barrett suite can also use the posterior corneal astigmatism both as a measured as well as a predicted. But you can use a nomogram, which is integrated into the Barrett suite. But as Shreyas was talking about, the TK formula, which is also from Barrett's, that actually uses a measured posterior corneal astigmatism to predict, especially in post-refractive surgery eyes. So the Barrett's Universal 2 is a virgin space formula, and we've already discussed about what all it uses, the A constant and the lens factor, which determines the AC depth, and it's applicable to all kinds of eyes, from the short to the normal and the long type of eyes as well. So the Barrett suite essentially requires at least the axial length, the keratometry, and the lens factor, which is derived from the SRKT factor. And the optionals are the AC depth, the white to white. So if you keep adding these 4 variables, any of these variables, the accuracy of the formula keeps going up. So the good thing is that if you're using a good optical biometer, not only will it take the axial length and the keratometries and the lens factor, which will be obviously fed in, but it will also give accurate AC depth measurements, the white to white measurements, and the lens thickness, and then of course the design factor. So you will get a much more accurate measurement if you're using a good optical biometer, which is feeding in all these parameters into the Barrett suite to give you the best outcomes. Now sometimes we would want to use measurements done by ourselves and put it into the Barrett suite online to the Barrett's calculator, but if we don't put all these 7 measurements, we will get a less accurate outcome than we would get if we were feeding all the data into it. So the lens factor is basically calculated out of the SRKT constant. The design factor is specific to each IOL, and we must. So there's a huge problem here. Most of these companies are very casual about providing you the correct design factor, and we've learned the hard way that even the best companies like Alcon and J&J, they will mess up on each IOL has a different design factor which they are supposed to provide you, and it does not automatically come on your optical biometer, and you have to keep checking that you have the updated current design factor for each new lens that you try to use. Otherwise you'll mess up your calculations. So in fact it comes as a very fine print under the place where you have the IOL power prediction using the particular formula. Please watch out for the design factor and the lens factor, whether it is fed in correctly for the particular lens you are using. So the Barrett's toric has again changed completely for our toric calculations, because it gives you, on my IOL Master 700, I basically get measurements from both the Barrett's K formula for the toric calculation, and I also use the Barrett's TK, which takes the posterior corneal astigmatism into account. So you can use either of the two. And then you also have the Barrett's True K post LVC formula, which basically is based on the Barrett's Universal 2. And it again, I will not go into the depth of how it works, but it is again one of our better formulas for the post-refractive surgeries. I'm going to finish in a minute. So what we actually are now using a lot is the ASCRS calculator for our post-refractive surgery eyes. And you can see here in better detail that it can take in measurements from various things, from your topographer, from your optical biometer, from the OCT, the OptoView gives the posterior corneal astigmatism, and also from the other devices including the Pentacam. Once you've fed in whatever data you have, so you don't have to feed in everything. If you have just basic data of the axial length and the keratometries, the more data you'll add here, the more chances that you'll have a better outcome. And this is how it gives you a printout. Depending on what all you've fed in, it kind of gives you on different formulas these various calculations. For example, here it's using the Sharma's, the Haggis L, and the Hill Pentacam formula, the OCT derived measurement. So it's predicting IOL powers based on this, and then it'll give you a summary of this. It'll give you an average IOL power based on the 4 or 5 different measurements that you fed in, whatever you had, and a minimum and a maximum. Typically in myopic LASIK, you'll end up going for the maximum here, but you have to obviously watch out for each of them in case there's a mistake. So again, from the pentacam, you can derive the EKR report, and that helps in the post-refractive surgery eyes. I think Shreyas has spoken on this total keratometry, so I'll just skip this. But frankly, also if you don't have, for example, a mature cataract and you're doing ultrasonic biometry for the axial length, you can still feed in that data into the Barrett's formula by taking all the other measurements from the optical biometer and just the axial length from the immersion scan, and that can still give you a close to predictable outcome. I think since I'm out of time, I'm going to stop here because we've discussed the only thing probably which I wanted to add in a moment is the super Larders formula, which uses many of these formulas from almost 100,000 surgeries. So it's an ever-growing formula. It's also artificial intelligence based, and there are some inputs from Uday Devgan to this among other people. And the two formulas which need mention are the Kane formula, which I really use for post-keratoconic eyes. Again, among the very good formulas today. In fact, this has become part of the ESCRS IL calculator, which I also use quite often now because it has all the latest IL databases available to it. It's a free formula for ESCRS members. And the EVO formula. These are the two very new, very predictable formulas in addition to the Barrett's. So it would have been incomplete for me to miss it. And I'll close with the ray tracing calculations, which are now possible with the Oculix software. These can be again done freely online by feeding data from several devices, including the Pentacam and the Anterion and others. So I use this on the Anterion. So I'll stop with that. These are the applications from the ray tracing. Thank you so much.
Thank you, Gaurav, for that excellent talk on, because there are so many formulae today, and then you have to kind of know when to use which formulae, because each one works differently in a different situation to get the best outcome for your patients. Now it is my pleasure to invite Dr. Savio Pereira, who is a senior consultant and director of the fellowship programs, FACO fellowship programs at Netradama Super Specialty Eye Hospital, and he'll be talking on the surgical evaluation and pre-op workup for premium IOLs. This is very important because today patients are very demanding and they don't want to wear glasses after cataract surgery. So over to Dr. Savio.
So the surgical evaluation and preoperative workup for premium IOLs, you've done your biometry right, and the most important thing for the preoperative workup, I would say, is that get to know your patient. Understand what are his hobbies, the interests, and what are their expectations. And in today's world, you have to give each and every patient the option of being glasses free, because we cannot say that, okay, they may not need glasses, and don't try to complicate options. It's very simple. You have astigmatism, you need a toric lens. If you are an active driver and you don't want glare and halos, you have the extended depth or the enhanced monofocals, and definitely you have the trifocals and the multifocals. So it's very important that you give these options to your patients. And one of the most important things, they will come and ask you as a surgeon, will I still need to wear glasses? Will I be able to drive at night? Is it reversible? You will get these questions, and you have to answer each and every one of them, because your patient will be very unhappy if you have promised something and not delivering. So as a surgeon, you can share your experience with different lenses. If you have a patient who has Parkinson's, who can't wear glasses, but at the same time has glaucomatous optic atrophy, putting a trifocal doesn't make any sense. You have to see the risk and benefits in each and every case, and where you individualize your IOLs. You may have got your biometry right, but at the end of the day, which patient is suitable for which, you are the best judge in your experience. For the patient, they don't know that. So what you need to understand is, most of the patients are undergoing some form of laser vision correction, and they want to continue that and be glasses free. And the type of IOL depends on the quality of the vision for the rest of their life. So this is something which is very important. Now sometimes you'll have a patient who has got a monofocal in one eye and says, I want to be glasses free. If you put a trifocal in the other eye, the contrast and the glare halos, it will not be tolerable. In this case, an EDOF or an enhanced monofocal will be much more better, or giving them a mix and match option is much more appreciable. At the same time, expected that the patient will have a good outcome. At the same time, try to get a continuous range of vision. So we know we have the distant, we have the intermediate, near intermediate, and the close reading. See what the patient already has before and try to follow it up with the remaining eye by checking the dominance, checking the tolerance. This is where you can individualize and customize the treatment for the patients. Coming to torics, just a small thing is that even in patients with keratoconus, pellucid marginal degeneration, post-keratoplasty, it will all be covered up. You should see if they are suitable for torics, and this is something with the EKR formula where you can see if there is a lovely peak that patient is definitely going to be very happy. While if it's a flattened out peak, they're not going to be happy with your toric lenses. Some of the contraindications, you have to break the bad news. If the patient has a bad pseudoexfoliation, subluxated lens, you have to tell them that you are not suitable for a trifocal lens. You're not going to be suitable, you're not going to be happy. Coming to angle alpha and angle kappa, I would say you should know this, especially in a premium IOL practice. If the angle is above 0.5, especially in the angle alpha, kappa is more for refractive surgery because the laser is fixed to the pupil, the laser tracking system, while angle alpha is the center, at the nodal point of the eye, while kappa is the pupillary center. So if you have a angle larger than 0.5, your patient is not going to be happy because the centration of the lens will be off. This is something very interesting. You have aberrometers now to your disposal. Remember here, the total always includes the internal and the cornea. And here you can see the cornea has not much, but the internal is contributing, and that is why you can have higher astigmatism. So this patient doesn't need a toric lens at all. And you can come to know the higher order abrasions from your aberrometers. You can know the asphericity, whether you are going to put an aspheric lens or a spheric lens and add to the spherical abrasions. Now, most of the lenses, being even premium monofocals, will say we have a plus 0.27 or a plus 1.8 or a neutral spherical aberration lens or aspheric lens. Depending on what type of the previous abrasions are existing in the cornea, you can adjust that and preserve that. If the patient has got a presbyon or a laser blended vision, you want to preserve that. Now, there are some few challenges in the very large axial length eyes. What do? You are not going to get lenses, be it trifocals or EDOFs, beyond a certain power. And if you have single digit lenses, most of us are aware that beyond 6 diopters, only you get the trifocal lenses, or sometimes only beyond 10. So you need to be a little careful which type of lens. The same thing in the very short axial length eyes. You have difficulty in the calculating the ELP. So what do? In these cases, you can definitely think of going for a monovision. This has already been covered, so I won't go into depth. This is an interesting case of a patient who had undergone 15 years back of an ICL implantation and LASIK, that was bioptics, 18 years back. And just to give you an example, if you miss out one thing, and you just do the IOL power calculation, you can see there's not much difference in the axial length between the two eyes. But by just putting the LASIK, that is the laser vision correction mode, the IOL power for the same lens changes from plus 0 to plus 2.5. So this is something, what you should do is get the biometry when the patient comes to you, and you can counsel your patient along with the biometry and say these lenses are suitable, these lenses are not suitable. And always, for the tough cases, do the biometry yourself. Just giving you an example, this is a patient who had decreased vision, a very high hyperope. You're not going to get your EDOFs or trifocals for these powers. So then monovision does work well in this. You can find out the dominant eye and the non-dominant eye and then go ahead and see. So here you can see the axial length is very shallow and the ACD is shallow. At the same time, you have so much variation in the IOL powers. You can see 46, 42 with the SRKT, 47, 46.5. There's so much of variation, and that's the time when you can do a multi-formular approach and then rationalize and go. So we did a monovision in this patient, and as you can see at post-op, the patient was very happy. So coming to the summary, always counsel your patients for glasses independence. Sometimes you may need to go for customized IOLs if the IOLs are not available. Micro monovision does work well, especially if the IOL powers are not available. Be careful in post-refractive surgery eyes. Do a multi-formular approach, check the refraction in the other eye, and always under-promise and over-deliver in complicated cases. The straightforward cases are always good, but the complicated cases will trouble you. Thank you very much.
That was excellent, Savio, and really enjoyed that talk as well. And now it's my privilege to invite Dr. Sri Ganesh, who's the chief instructor of this course and a dear friend. And this is a fantastic course, and that can be made out by the big attendance we have for this course as well today. So Dr. Sri Ganesh, who's the chairman of the Netradhama group of eye hospitals in Bangalore, he's going to be speaking on mastering toric IOL implantations. He's gone on to become, I think, the secretary of the Intraocular Implant Club this year. And among lots of other achievements and innovations, Sri Ganesh is a prolific surgeon and a dear friend.
Thank you. Thank you, Gaurav. And good afternoon, dear friends. the okay. So to start off with, when we look at toric IOLs, the number of toric IOLs being implanted is growing, and in our practice, nearly 50% of patients require a toric implantation. The reason is, if you want to get a good result, you need to have a residual astigmatism of less than half a diopter. Otherwise, the patients are unhappy because the quality of vision deteriorates. Now, if you're looking at refractive cataract surgery, either for monofocals or multifocals, it's more critical for the premium IOLs like multifocals and EDOFs that you correct the astigmatism. And clinically significant astigmatism is astigmatism more than 3/4 of a diopter. So you need to aim for getting the post-op astigmatism within half a diopter. So let's look at some of the main points for a toric IOL implantation. One is the biometric formula, which has been covered in detail by Shreyas Ramamurthy and Gaurav Luthra. Then you have marking of the axis, implantation and alignment. Then implantation in challenging cases like small pupils, because again the toric marks are in the periphery and then it's difficult to align the lens. Then the last is the rotational stability. If you look at biometric formula, so for torics, when the first torics came in, we had a lot of refractive surprises because we didn't know anything about posterior corneal astigmatism. We didn't take that into consideration. Doc Koch was the first to describe this posterior corneal astigmatism and how it affects outcomes, and he came up with a Baylor nomogram where actually you undercorrect with the rule astigmatism and overcorrect against the rule astigmatism, and that was a kind of a guideline that gave better results. And now you have the Barrett TK toric formula, and that's what we use with the IOL master, which gives you both the anterior curvature and the posterior curvature. It takes into consideration the PCA. Now, most online formulas for toric lenses also take into consideration the PCA, and this is something that you have to use when you are doing your biometry for a toric IOL. Marking of the axis is very important, but because if you don't have your toric IOL on axis, then you will have residual astigmatism. If you're off axis by 10 degrees, then you lose almost about 30% of the toric power. If you're off by 30%, then you lose all effect. And then if it goes beyond 30%, then you can actually increase the astigmatism. So it's very important to place the lens on axis. You will have to know how to mark the 0-180 degree pre-op with the patient sitting up, and then because to compensate for the static cyclotorsion that happens when the patient goes from sitting to lying down. And then again mark the placement of the axis and place it correctly. Nowadays you have markerless systems like the Callisto from Zeiss, the Varion from Alcon, and if you're using a femto, then the Flax platforms like the LensAR has the IntelliAxis where you get nubs on the capsulotomy, so it's very easy to place it intra-op, like in this diagram here. You get nubs on the, and even post-op you can actually see whether the lens is aligned. Okay, so this is again technique of implantation. Now I like to implant the lenses under BSS, because if you have viscoelastic and you don't remove the viscoelastic completely, if you have visco under the lens, what happens? The IOP goes up, and especially in myopic eyes with large bags, the whole eye is compliant. It expands when the pressure goes up. The bag can open up, and then there's a higher risk of rotation of the lens. There's also a paper by Abhay Vaswada which said that eyes with longer axial lengths have higher rotation of toric IOLs. So I like to implant under BSS, and I like to leave the eye a little soft at the end of the surgery. Don't overpressurize the eye, because then it can rotate, and most rotations happen in about the first 6 hours after implantation. And don't ask the patient to lie down for some time, not immediately walk around. Let's place this video. So yeah, so I just fill the chamber with BSS. You can also have an irrigating cannula. I don't use an irrigating cannula. I just form the chamber with BSS, and this is actually a screw type lens. So both screw type and shooters, you can use this technique. And I just nudge the lens into the bag, and you can see that it's on axis with the Callisto. That's the Callisto system. and that actually helps you reduce your surgical time, putting in viscoelastic, removing viscoelastic, leave it a little soft at the end of surgery so that the lens does not rotate. You have to wait for the lenses to open because many of the hydrophobic lenses take a very long time to open. So if you're impatient and you shift the patient before the lens has opened up, then the contact with the bag and the fornix is not adequate and these lenses will rotate. Today lenses have textured haptics or rough haptics so that you have a better contact and lesser incidence of rotation. So select a lens with such a haptic so that you have lesser incidence of rotation. So we also did a study to evaluate the rotational stability. We had two groups, one implantation under BSS, one with the viscosurgical device, and 100 eyes of 100 patients, 50 in each group, and we followed them up for a year. And this is what we found, that the rotation was much lesser. This is the amount of rotation, 0 to 5, 5 to 10 degrees, and more than 10 degrees. And you can see that the rotation was much lower in the BSS group. What happens to small pupils? So I've made a marker known as the Ganesh toric marker because you can't see the peripheral marks if the pupil comes down. So this is available from Epsilon. You can just, it has a blunt edge and two windows. You can kind of look at the toric marks through the windows and then press down on the lens. When you press down on the lens and hold it for about 30 seconds, it kind of leaves an indentation and a mark on the center, which is temporary. This is not a sharp edge, it's a blunt edge. And then you can see that, you see that mark very clearly. You load the lens in. So sometimes after flax or even intraoperatively, the pupil constricts. So by the time you have finished your phaco, you have a pupil that is constricted and then you can't see the lens placement correctly. This is not a very small pupil because I want to show you the peripheral marks also and how the alignment happens. This is injected into the capsular bag and I'm using the Callisto system, so you can actually rotate. Though you can't see the peripheral marks very clearly, you can align the central indentation and the mark very clearly. This is a temporary mark, it disappears in about 5 minutes. And next day we have even done tests. We have looked at the quality of the surface, we have looked at scatter. There's no difference from a regular lens. So by the time you finish your surgery, it's almost disappeared, the indentation. But you can make sure that it's aligned at the end of the surgery. And we also did the eye trace. This is the eye trace of that patient. You can see that it's perfectly on axis. Coming to rotational stability, again, you have capsulotomy fixated lenses like the Femtis, and this is my own design of the swivel haptic IOL. We're going to start multicentric trials for this, and then we hope to commercialize it in a couple of years. So with capsulotomy fixated lenses, you place the lens into the capsular bag. You have the swivel haptics, which you can swivel over the anterior capsule. So it captures the capsulotomy. Even with the Femtis, you have flanges which capture the capsulotomy. So the advantage is there's absolutely no rotation. With my lens, you can even go under the IOL and then remove the viscoelastic, and it's perfectly on axis. The lens does not move in the post-op period. You can see this is the result at 2 weeks. So that's few of the pointers for toric IOL implantation. And I would like to invite you for the 37th APA-CRS, which is going, again, an international meeting which is going to happen in August in Ahmedabad. Thank you very much for your attention.
Thank you, Dr. Ganesh. That was an excellent and very insightful talk. I think so far, Dr. Shreyas covered points about biometry, how important it is to measure the posterior cornea, measure the fovea, and also see the central topography, after which Dr. Gaurav covered points on which formulae to use, and Dr. Ganesh has, and Dr. Savio, of course, the surgical evaluation, and then toric lenses. So it's my pleasure to introduce Dr. Sushmita Sri Ganesh, who is a cornea, cataract and refractive consultant at Netradhama Super Speciality Eye Hospital in Bangalore with us. And today she is going to give one of the most complex subjects that we actually have today, which is the IOL power calculation in special situations. Now these situations can be post refractive surgery, post RK, keratoconic eyes, and post-corneal grafts. So we're very excited to hear this talk, and over to Dr. Sushmita.
Thank you, and good afternoon to everyone present here. So today my topic for discussion is IOL power calculation in special situations. So what are these special situations that we can come across? The first one, which is most relevant to this IC, is post-refractive surgery. A lot of people are undergoing refractive surgery, especially PRK, LASIK, and KLEX these days. The global demand for refractive surgery has increased quite a bit, with a compounded annual rate of increase of about 4% from 2019 to 2024 itself. So this group of people are the ones who will come to us in the future for cataract surgery and demand a good refractive outcome. The next group is in corneal ectasia. Various studies have shown in India a prevalence of keratoconus to be from 0.6 to 2.3%. Also, some studies have shown prevalence of subclinical keratoconus in the patients undergoing cataract surgery to be as high as 27.5%. So it is important in these patients as well to give good refractive outcomes. Then comes a small niche group of patients who have undergone keratoplasties such as PK, DALK, or even endothelial keratoplasties, and it can be quite challenging to perform biometry in these cases. So the first is post-refractive surgery. These patients will come to us with quite high expectations because they have been they've had spectacle independence for most of their life, and they usually come requesting for premium IOLs. And the challenge for us is that certain studies have shown that less than 70% of eyes who have undergone refractive surgery as well as cataract surgery have a target refraction of plus or minus 0.5 diopters. So what are the sources of errors that we usually encounter? This is index error, instrument error, and formula error. So in index error, we can see that in post-myopic LASIK or PRK, there is a central flattening of the anterior curvature. In post-RK, there is a flattening of both the anterior and posterior curvature as well as mid-peripheral steepening. In post-hyperopic LASIK, there is a central steepening. So the keratometric index of 1.3375 is usually assumed if there's a constant relationship between the anterior and posterior radius of curvature, which is the Gall-Stranz ratio. However, in post-refractive surgery, this is altered. So we cannot consider this standard keratometric index, which is used in the usual IOL formulae for estimating the effective lens position. The next error is the device error. Most manual keratometers and autokeratometers take the measurement from the paracentral cornea in order to get a SIM-K which has the assumed central corneal power. However, in post-refractive surgery, usually this leads to a false high K value. So in myopic LASIK, PRK, or SMILE, there is an underestimation of the IOL power leading to a hyperopic surprise. Whereas in hyperopic LASIK, there is an overestimation of IOL power leading to a myopic surprise. So how to tackle these errors that we come across? Various biometers are available to us, such as the IOL Master 700, which uses the telecentric keratometry and swept source OCT in order to get the total keratometry. As Dr. Shreyas has already mentioned, this takes into account both the anterior as well as the posterior corneal curvature, and also has the integrated Barrett TK formulae. Also, we have various other Scheimpflug-based topographers and OCT-based biometers which help us calculate the anterior and posterior corneal curvature. There's also correction factors which can be taken into account for the corrected keratometric index. These devices, which have already been discussed, help us calculate the true net power, total corneal refractive power, as well as equivalent keratometric readings, which can help us get more accurate K readings post-refractive surgery. The third error is formula error. The various Virgin's formulae that we use take into account the axial length as well as the K for the effective lens position estimation. However, post-refractive surgery, there is a flatter K. This leads to an underestimation of the ELP and an inaccurate IOL power calculation. So there are various formulae that over time have evolved for IOL power calculation in post-refractive surgery eyes. One is the historical data, which means we need both the pre and post-operative K values as well as the refraction in order to use these formulas. I will not go into detail too much about this because it involves a lot of mathematics, but some of the time-tested formulae that have been used are the partial history method where we take the pre and post-operative K using the Aramberry double K or the Barrett true K partial history. However, this is a more practical scenario for us, where we get patients who have undergone refractive surgery many years ago and come to us with no historical data. So some of the formulae that can be used are diffraction-based formulae like the contact lens method as well as the intraop aberrometer. There are certain post-operative K readings which can be taken in formulae which incorporate just the anterior corneal curvature, which have shown to be quite accurate, such as the Bangkok-Maloney, Sharma's PL, Haigis L, and the Barrett True K no history method. Also, taking into account the anterior and posterior curvature, the Barrett Universal 2 formulae using the Swepsos OCT devices give a very predictable outcome. Ray tracing formulae also have good outcomes. This is done by calculating the true corneal power. So the ASCRS online calculator is a very useful tool for us. It's an open access and free calculator that helps us calculate the IOL power in these kind of patients. They have 3 modules, both the myopic, hyperopic, and the RK module, and the formulae that are commonly used in this are the double K holiday, Sharma's PL, Haigis L, OCT based formulae, and the Barrett True K. So the IOL of choice, we have to take into account this as well when choosing, when doing our biometry. Myopic LASIK or PRK leads to a positive spherical aberration, so it's ideal to take a negative spherical aberration IOL, also an aspheric IOL. In hyperopic LASIK, it's reverse, where there is a negative spherical aberration, so we should consider 0 or positive spherical aberration IOLs. Toric IOLs, multifocal and EDOF IOLs can also be considered. These should be considered when there's a low refractive error correction that has happened, a perfect centration of the ablation, low higher order aberrations, and good EKR distribution curve. Just to make it a little more simple, this is a case of a patient who had undergone RK 35 years ago. RK scars present. The cataract was greater in the left eye, NS3cc with a myopic fundus. Best corrected visual acuity was 612 in that eye. So we performed a pentacam topography, and we saw that there was a pretty central flattening, and this is the EKR curve. So this is how we usually do it in our center. With the IOL Master 700, we calculate various formulae, usually the Barrett True K, Universal 2 TK, the Pentacam Central K, which is incorporated into the Barrett formulae, the Pentacam EKR Holiday 2, and the MS39 ray trace. So we compare all of these, and we have found in our center that the Pentacam Central K values provide quite accurate outcomes in post-RK patients. So the patient underwent surgery with this plus 23 diopter lens, and we try and target a little more myopia. And post-operative BCVA was 6 parts, with this being the refraction. The second case is in LASIK, with a patient who had undergone LASIK 20 years ago with cataract in the right eye greater than the left eye and BCVA of 6/9. So we performed the EKR maps, as you can see here, and right eye phaco was planned. In post-LASIK and post-SMILE cases, we usually consider these formulae: the Barrett Universal 2, Barrett True K, Barrett TK True K, Haigis L, Haigis TK, and Pentacam EKR Holiday 2. So we try and take the higher IOL power. Usually the Barrett True K is pretty accurate and gives a very predictable outcomes. The post-op refraction was 6/6 and 6, and this being the residual refraction. My next topic, which I'll go through quickly, is in corneal ectasia. The previous speakers have already touched on this. It is quite difficult to get the K reading as well as the axial length reading in these keratoconic eyes. The deviations are usually due to the deviation from the corneal refractive index, the visual axis being slightly displaced, an irregular tear film, and usually we encounter hyperopic surprise in keratoconic eyes. So keratometry and biometry can be done ideally using elevation-based topography devices rather than the manual and automated keratometers, because they are not reliable. Also, we prefer optical biometry rather than ultrasound because the visual axis does not coincide with the corneal apex. So these are the formulae that can be used for keratoconic eyes, but the most accurate keratoconic formulae are the Barrett Universal 2 formulae and the Kane keratoconus formulae. This is how they perform usually, and it is important to target a higher myopia in keratoconus eyes based on the degree of keratoconus and the formula that we used, as you can see in this table. Now, the IOL of choice is a monofocal single-piece non-spherical IOL. We should take, non-aspheric IOL. We can also consider toric IOLs if it's a non-progressive keratoconus, and as you can, I'll just briefly go through this case, which is both eyes keratoconus stable, left eye having more cataract, and you can see in the pentacam it is a pretty regular cornea. So we opted using the Barrett toric TK to undergo a toric IOL implantation. After the surgery, the patient had no residual refraction with uncorrected visual acuity of 6.6. Post-keratoplasty, it is quite challenging. As we all know, there's a change in both the anterior and posterior curvature in these eyes, which makes it difficult to do both the K readings as well as axial length. So usually in suture keratoplasties, we wait 2 to 3 months after complete removal of the sutures. Certain topographers help us get corneal true net power, and optical biometry is preferred. Also, 3rd and 4th generation formulae are preferred. In triple procedure, we can take previous cases, K readings done from the same surgeon, average estimated post-op K from literature, or even K values from the fellow eye. In DSEC and DMEC, it is important to note that there's a hyperopic shift mostly in DSEC, so we should target a myopia of at least -1 diopter. Ray tracing has also proved to be quite good. So there are various formulae that we can use, as already mentioned, but the IOL of choice, usually if there's a higher degree of astigmatism, we can do a stepwise approach where we first do femtosecond astigmatic keratotomies, usually greater than 8 diopter of astigmatism, or we can choose a toric IOL, which does help reduce the astigmatism. That's all for my talk. Thank you.
Thank you very much, Dr. Shushmita, for dealing with a very complex subject. We are going to get more and more patients coming in after LASIK and SMILE. I started doing RK nearly 30 years ago, and now we are seeing a lot of these RK patients coming in for cataract surgery, and it's very difficult to calculate and get them to emmetropia. Most of these refractive surgery patients are also very demanding because they've enjoyed freedom from glasses, and of course the ectatic conditions and keratoplasty, of course, they're all complex situations. So now we'll go on to our next speaker. It's my pleasure to introduce Dr. Supriya Sriganesh, who is a senior consultant cataract and refractive surgery at Nethadama Super Speciality Eye Hospital, and she's also the executive director of Nethadama Hospitals Private Limited. And she's going to talk to us today on managing post-op refractive surprises. So you have done everything for it to go right, but when it goes wrong and when you have a dissatisfied patient, how do you manage them? This is very important. It's not only how you get into Chakravyuha, but also how to get out.
Thank you so much for that kind introduction. It's always a pleasure to be here at this IC, and I have an interesting topic today, managing post-operative refractive surprises. So when you have a patient who selected a trifocal lens, an expensive package, and then they develop a post-operative refractive surprise, how do you deal with them, and how do you figure out what to do next? So the first thing you need to do is go back, right? Go back and check your biometry, recheck whether you've used the correct IOL formulae. Have you used something to correct their cylindrical power like a toric lens or LRIs? Have you operated on the right patient and the right eye? And has any of your staff done a human error while entering the data into your system? So the moment you know what has gone wrong, then that calms you down, and then you can figure out what to do about it. So when you have a minus residual refractive error, always check whether you've done the adjustment for a sulcus IOL. It can also happen in bag distension syndrome and or capsular contraction syndrome. So make sure you dilate the patient and look for these things. If you have a plus residual refractive error, check whether this patient has undergone refractive surgery in the past, has not told you about it, and you've missed possibly a PRK done in the past or something like that. And plus residual refractive errors can also be seen with plate haptic lenses. Okay, so we already went into this, so I'll not cover it again. So now that you have the residual refractive error, what are your options? Now you have non-surgical options. If your patient doesn't want to go in for a secondary surgery, you can always prescribe them spectacles and contact lenses. If they are more comfortable with that, better not to touch the eye. What are the surgical options? Now you have cornea-based procedures and you have lens-based procedures. once the lens is in, if it is a monofocal lens, you can do cornea-based procedures, PRK, LASIK, SMILE. The other option is to do lens-based procedures. If it's just a rotation of a toric IOL, you go back in and rotate it back into the correct position. You also have the options of implanting a second piggyback IOL into the sulcus. You have an option of implanting a piggyback ICL. You can just take out the IOL and exchange it with the correct lens, or you can also do an optic capture, which is an interesting option which we'll be seeing. Okay. So when do you opt for these? How do you make these decisions? So cornea-based procedures you opt for when it's a low refractive error. So if you have an error less than -2 diopters, there's no other corneal pathology in the eye, no significant dry eye, because these patients are older. You have to be a little careful about doing LASIK in these patients because their dry eye can worsen. You need to make sure that there is no other photic phenomenon, dysphotopsia happening in the eye, then you can select. How long do you wait? You need to wait for at least 3 months after the initial surgery and make sure that the manifest refraction is completely stable before going ahead with a cornea-based procedure. Now, the eye trace is a very interesting and helpful tool for us in toric IOL rotation, and the rotation ideally must be done within 2 weeks. So we usually call the patient back after 1 week, dilate them for an axis check, and make sure that the lens is on axis. In case there's any rotation, we also get an eye trace done. Now, this module in eye trace tells you exactly how much rotation will give you how much change in cylindrical power, and accordingly you can rotate the lens back into position. Now, coming to the IOL piggyback options, this is how do you calculate the power of the lens, right? For the piggyback lens, this is an axial length independent calculation. So you have to do a very careful manifest refraction calculation. And for hyperopic errors up to 7 diopters, the spherical equivalent is multiplied by 1.5. And for hyperopic errors beyond 7 diopters, the Holiday R formula or refractive divergence formula can be used. So this is an overview of how you do the piggyback IOL calculations. For an underpowered pseudophakic, that is, if you have a hyperopic residual refractive error, depending on the length of the eye, you do, for short eyes, you multiply it by 1.5 and add +1. For an average eye, it's 1.4. For a long eye, it's 1.3. Similarly, for myopic residual refractive errors, you -1. So for a short eye, you do 1.5 into the spherical equivalent, average eye 1.4, long eye 1.3, but you -1. So this is just an overview of how to calculate the sulcus. Now, which lens to use as a piggyback? You have multiple options. We use the Rayner Sulcoflex. You can also use 3-piece silicone IOLs which are available, and you can also use an ICL as a piggyback lens. So this is a little bit about the Sulcoflex. It has a hydrophilic acrylic IOL, and basically it has a round edge and it has a concave posterior surface with a convex anterior surface so that it can fit nicely into the sulcus. But there are complications of polypseudophakia. If you do a piggyback lens, you can have pigment dispersion, pigment between the IOLs, iris transillumination effects because the IOL is rubbing on the iris. You can also have uveitis, glaucoma, and something called interlenticular opacification, and also a hyperopic shift. So you need to keep in mind and counsel your patients that these are a possible complications of piggyback IOLs. So now let's look at some interesting videos. This is a case of a patient who was actually post-RK, and this patient had a residual refractive error. So this is Dr. Ganesh's video where you can see this dense PCO. The posterior capsular opacification was removed by going under the lens and doing a posterior capsulotomy, after which the Sulcoflex piggyback IOL was used. So here the lens is neatly implanted into the sulcus, and this patient was actually a post-RK patient in both eyes. So what was planned was a mini monovision in both the eyes with the Rayner Sulcoflex lens, and in this eye the posterior capsulotomy was also done. So you see here at the end of the surgery, it's post-RK, the central opacity is cleared and the piggyback lens is in place. So although this is a complex procedure, You see both the lenses in place there on the ASOCT, and you see here after doing this for both the eyes, this was what the refraction was. The right eye was seeing better for near, the left eye was seeing better for distance, and binocularly this patient was very happy. So imagine in a post-RK eye doing a piggyback lens and achieving mini monovision with 6/6 outcome is very interesting and an excellent outcome. So now coming to IOL exchange, in a lot of scenarios you need to be able to exchange the lens if you have a residual refraction. This was one such case where the patient had a trifocal lens which was implanted. I'm not able to play the video. Can you help me? I'm not able to go back, please. Yeah, thank you. So this is a trifocal lens which is in place, and this is a technique for IOL explantation. So you need a particular toolkit of instruments. You can see here there's not much opacification, so you can put visco into the bag, lift up the lens, hold the lens with the lens holding forceps, and the lens cutting forceps is used to cut it 3/4 of the way. So you don't need to cut it all the way, 3/4 of the way, but the incision needs to be extended a little bit in the shape of a trapezoid. So you hold one edge and rotate the lens out using the trapezoid incision. It comes out very easily with very little manipulation, and the correct powered IOL can be implanted. So this is one of the techniques for IOL exchange. Okay. Now this is another case where we see, sorry, can you play the video once again? Can you go back, please? Yeah. Yeah. Sorry. You're not able to play it? I had checked it was playing. I just checked it was playing. All right. So I think this video just highlights the importance of when there are adhesions, a fine iris repositor can actually be used to remove those adhesions. I think in the next video also we can see that. See, look, this is a plate haptic lens. So fine iris repositor again is used to actually dissect these adhesions. This can be very valuable step, and a dialer is just used to pick up the lens out of the bag. Now we have to be very careful when these adhesions are there, because you can cause a ZD. So again, a fine iris repositor is used to completely separate the lens from the bag. Now these can be very tricky situations. Here most of the lens is removed from the bag. In plate haptic lenses, we cut through the middle of the lens, the entire lens, and remove it piece by piece. Now while removing the left piece, you see here that adhesion is not removed, so it's pulled. So there's a ZD that happens there, and this is a Nightingale polisher which also can be used to polish off the PCO. So this is an excellent tool which can use, it's a blunt non-traumatic polisher, and here the bag is again inflated with viscoelastic, and a CTR is used to stabilize the bag. Now once you know that the bag is completely stable, it is safe to implant a trifocal lens in the right axis and the lens of the right power to make sure that the IOL stability is achieved. So here you can see the bag is stable and the lens is implanted. Okay, so this was actually a patient who was very uncomfortable with the trifocal lens. So a monofocal lens has been implanted after the IOL exchange. So I'm ending with one last case, which is an interesting case scenario. This was a 54-year-old female ophthalmologist who came in for an opinion for refractive correction. She wanted to get rid of her glasses. This was what her refraction looked like. Clear lenses, normal retinal examination, but this was the topography. So she was not actually suitable for a corneal refractive procedure. because of a borderline cornea. Now, anterior chamber depth was also very less. It was 2.32 and 2.27 in both eyes. So she was also unsuitable for a toric ICL. So the surgical plan was femto laser assisted refractive lens exchange with the implantation of a trifocal IOL and arcuate incisions. The calculated IOL power was plus 15.5 diopters and 11 diopters, and this was what was planned. Now, the surgery was completely uneventful, but 3 weeks post-operatively, she had blurred vision, and you can see with a trifocal lens, she was only seeing 6:12 and 6:9 for distance vision. So she was quite unhappy after the procedure, but with correction, she was improving to 6/6. So this is clearly a residual refractive error. Trifocal lenses are in, and this is an ophthalmologist, right? So it's a tricky situation. What do you do? So this was, again, the AIOS2025-IC338-Target. So you can see here the anterior hyaloid phase and the structure of the IOL and the posterior capsule that's there. So a very interesting way of management was done. We'll have a look at that here. So the incision was carefully opened up. The same incision was opened up. All right, and here you can see that after injecting viscoelastic and carefully dissecting the edges of the capsulotomy which were fused to the IOL, make sure all the adhesions are carefully dissected and removed. A little bit of visco is also injected under the capsulotomy into the bag. Now, this was Dr. Ganesh's case, and he's injecting visco into the bag because he's planning something very tricky. Here, a side port is made, and look at this. This is a cystotome. He's actually going under the IOL and performing a posterior capsulotomy. So why is he performing a posterior capsulotomy in an eye with a trifocal lens? Because he's planning a posterior IOL capture. So here you can see that the residual refraction was about 1 diopter. So you just need a change in position of IOL to cause that change in 1 diopter. So very carefully, a posterior capsulotomy is done using a forceps. Here, it is a tricky situation, and it needs to be very carefully managed. One of the ways is visco is injected into the primary opening so that you create space there to do your capsulotomy. And a good posterior capsulotomy is achieved. After that posterior capsulotomy is done, the IOL is actually captured into the capsulotomy. Now, it's a very meticulous movement because you cannot afford to have a vitreous loss here. Carefully, the trifocal lenses were captured into the posterior capsulotomy, and a meticulous removal of viscoelastic was done. So after this, you can see how the refraction changed. So exactly what we were looking for, and the spherical is 0, patient is seeing 6/6 for distance. And this was the clinical picture, perfectly stable IOL and the good refractive result. So the take-home message is, of course, prevention is key for a post-op refractive error, but you also need to communicate with your patient, speak to them about what has happened and what are their options. You need to have an algorithm in your mind to manage the refractive error, and like you saw in the last case, even very unconventional options can work well. So you need to think out of the box and also be a very skilled surgeon for the last case. But these are the options and how to manage the residual refractive errors. Thank you so much for your patient listening.
Thank you very much. And as we come to the end of the session, if there are any questions from the delegates, please. Mike, please.
I'm just missing your name, Dr. Sushmita. Yeah. In one of your presentation, you had said that it's a post-RKI, where a femto-assisted laser cataract surgery, just to calculate that IOL power calculation. My question is not actually pertaining to that IOL power calculation, but in a case of RK operated case, and if you are planning a femto-assisted, what all precautions should you take, and what are the minimum cuts that you expect to proceed with the femto-assisted laser cataract surgery?
Basically, when you are doing a femto-assisted cataract surgery in a post-RK, you will have to look at the scarring which is there and epithelial plugs. If you have thick epithelial plugs and scarring, this can block the laser and you can have tissue bridges. So it's very important that you don't do flags in cases where there is scarring post-RK. That is one issue. The second is if there are multiple incisions, Sometimes you have 32 incision RKs. In these cases, if you do a clear cornea, then the RK incisions open up, and then you can, it's very difficult to manage, it's very difficult to suture. So all these cases you have to do a scleral tunnel. If your RK incisions is a 4 incision or 8 incision RK and there's adequate space between the incisions to make a 2.2 incision, then you can do a clear cornea and then manage. Docking is not an issue. Docking is not an issue. You get a good capsulotomy also. So routinely I've done quite a few cases. Only thing is you may not get a completely free floating capsulotomy. So I always kind of go in, use the forceps, and then do in a rexus-like motion. So if there are any small tags, then you don't have a runoff. Yes.
Sir, I have a question. Sir, in the last case which Dr. Supriya presented, not that as a beginner surgeon some ophthalmologist will come to me for a cataract surgery, but just if I have other normal patients, sir, and if I encounter a similar situation, so what would you advise? Because I'm not that comfortable with the PCC right now.
See, the options were, one is to do a refractive surgery correction, but the problem is 54-year-old female, she had some amount of dry eye and her corneas also were abnormal. So you can do a PRK. So in older patients, the chance of it going in for ectasia is more, but she didn't want a cornea procedure. Okay. She said, no, I don't want a cornea procedure. The other option was an IOL exchange. Now we again recalculated with biometry, and it was turning up to be the same lens power. So I don't know whether there is a manufacturing mislabel, because the other eye was okay, whether there's a manufacturing mislabel. If so, then yes, if I exchange the lens for the same power, it'll be okay. But again, it's a tricky situation. So it's not showing you a different lens to exchange. And so you can't do a lens exchange. Then for piggyback lens, I told her the option is, okay, you can put an ICL or a piggyback, but she didn't want 2 lenses in the eye. She said, no, I don't want that. So then I was just racking my head as to what I can do, and she was unhappy. And these patients with trifocal, if you have a myopic residue, then their night dysphotopsia increases. And they're miserable. So it's okay to have slightly plus 0.25 rather than to have minus 0.5 or 1 diopter. And then I was thinking, what can I do? Then I thought, okay, what if we can shift the ELP? If you shift the ELP posteriorly, you get a hyperopic shift that will correct the myopia there. Yes. And that's how I kind of said, okay, I'll plan this. I discussed with her. I said, okay, I do pediatric cataracts. I'm quite comfortable doing a PCCC. So I said, we can try this and do it. And she said, okay. And then, so that's why I have this interesting case.
So, but if the biometry had some changes, in that case, the lens exchange would be a
yes.
better...
you can do a lens exchange. If the biometry showed you a totally different power, then maybe there was some problem in the biometry, maybe dry eye when you did the biometry, or because of an optical biometry. Usually the difference is because of dry eye, because with the IOL master, you see the foveal pit, the axial length measurements are very clear. So it's usually the K readings. And in myopic patients, again, because of the ELP calculation problems, you can have a little bit of surprise. If there was a big difference, then you could do an IOL exchange. But this was a small, like 0.75 or so, so shifting the ELP kind of helped.
Thank you, sir.
Thank you very much for all the interesting talks. Just one quick question. When you are implanting a sulcus piggyback lens, does it matter what material the original lens implant is, whether it's the old silicone type lens or whether it's a hydrophobic lens or hydrophilic lenses? Do you have to match materials?
You don't have to match material. It's better not to use the same material. The guideline is don't put 2 lenses in the bag. So if there's a lens in the bag, then you put the lens in the sulcus for a piggyback, if you're using a piggyback. So you can put a 3-piece lens in the sulcus, and suppose there's a silicone lens in the bag, then you use a hydrophobic lens in the sulcus. So if the material is different, then the chance of the interlenticular opacification is less. So that's the kind of guideline.
So you want to deliberately mismatch?
Yes, deliberately a different material.
Thank you.
I operated one case with a hypermetrop, axial length around 19.9. Barrett and Haggis, all formulas were showing result around 34 IOL power. I implanted the same EDOF lens, but my surprise, I did the patient both eyes simultaneously. Both eyes were having the similar size, and I got the surprise of -4. So what is the reason? Means why I should what I miscalculated? Yes, I operated one eye again with the Sulcoflex from Care Group, and it was 6/6, and other eye I kept -3 only. So patient is happy, but I don't know what went
See,
wrong.
there are many things that can go wrong. One is the formula. I usually like to look at the, for high hyperopes, I like to look at the Hoffer Q. The Hoffer Q is actually kind of in small axial lengths, the Hoffer Q may be little more reliable. But the Barrett also gives good results. The problem is also in the effective lens position, because even a small shift in effective lens position for a high powered lens will give you a big refractive surprise. And sometimes the design of the haptics can make a difference, because if the design of the haptics is not okay, or if you have long haptics, most of these high hyperopes have small bags. So sometimes you can have like an anterior shift of the lens, and then that changes the ELP, and you can get a myopic surprise.
Checked AIOS2025 also. Bag was lens was in the bag and towards the posterior surface only.
Okay.
But and Hoffer Q was also showing same 33 only. Still -3 error.
So it is notorious. The short axial lengths are notorious for refractive surprises. The non-ophthalmic eyes, so you have to be quite careful. But if you have some amount of myopic surprise, if the cornea is normal, you can always do a corneal refractive surgery.
Patient
Because even if you
only, so
even if you exchange the lens, you can still have a surprise, because you never know the ELP and where the lens is going to sit.
I didn't opt for IOL exchange.
Yeah. So you can do a Sulcoflex, or you can.
Yes, I go for.
Yeah. Thank you. None of them, yeah. Too short, yes. But you'll get a hyperopic shift. You'll get a if the ELP is deeper, you get. Okay. It is a difficult situation. Yes, I think we'll take the last question and wind up, because we are.
Thank you for such a nice presentation. I have a question for Toric IOL. Suppose we did a perfect pre-op evaluation, everything done perfectly, and we get surprises of plus 1.5 diopter of astigmatism. What will be the chances of error in?
See, basically you look at the.
Suppose the patient is come late after 3-4 weeks. Can we do rotation or repositioning of the IOL?
See, one of the commonest reason why you get a surprise is if you have dry eye pre-op. If you do your biometry and then the patient has dry eye, you can have the K readings off by almost like 1.5 diopters, and post-op you'll get a refresh. So you have to see that the ocular surface is pristine when you're doing your biometry. That is one aspect. The second is when you have a rotation, generally you have mixed astigmatism. You have plus and minus. You'll have like +1, -2. So you know that, okay, if you rotate the lens, you're going to go to plano. You have an online formula, astigmatismfix.com, or you can use the Barrett RX formula, or you can use the iTrace, and that will actually give you the amount of rotation and what will be the residue. If you go to astigmaticfix.com, you have that. You can put in the model of the lens, and then what is the post-op residual refraction. It will tell you how much to rotate, whether rotation will help, and after rotation what will be the residue. And you can rotate. Generally I prefer to rotate after a week or 2, because then the bag is a little sticky and then the lens does not rotate so much. So if you rotate immediate post-op, there's a chance of re-rotation. So you wait for like 1 or 2 weeks, the bag is a little sticky, it has collapsed, Then if you rotate, then the chance of re-rotation is less.
But the question is why patient came late?
You can open up the bag. Even at 1 month, you can kind of open up the bag. You do a visco dissection and fill in viscoelastic, and you can rotate it.
Okay, thank you.
Thank you. So as we end this session, I would like to thank the faculty and all the delegates who have come here in spite of the lunch break. I think we had an excellent session, good discussions, and hope to see you next year. Thank you very much. Enjoy the conference.